Quality Watch is an educational production of iPro. Opinions expressed reflect the views of the speakers only and not those of any company or agency. This podcast is intended for private, non-commercial use only. Please visit ipro.org to read our full disclaimer and terms and conditions.
Welcome to Quality Watch, the podcast focused on healthcare quality improvement. Quality Watch is a production of iPro, a trusted partner of federal and state agencies working to measure and improve the quality of healthcare for all. I'm your host, Dr. Edison Machado, Senior Vice President of Strategy Solutions here at iPro. In today's episode, we'll cover a hopeful new FDA-approved non-opioid pain medication, PFACs' role in public health, and more. But first, a few quick headlines and updates from around the nation and here at iPro. Recently, the first H5 bird flu death was reported in the United States. While the CDC continues to assess that the risk to the general public remains low, people with job-related or recreational exposures to infected birds or other animals are at a greater risk of infection. The FDA has approved a new class of non-opioid pain medications. Jornavix, the first drug to be approved in this new class of medications, targets a pain signaling pathway in the peripheral nervous system to reduce pain. Experts say that this is an important milestone in public health and acute pain management, offering an opportunity to lessen the risks associated with opioids for pain use. And here at iPro, Deborah Santiago, the Senior Director of Independent Dispute Resolution, has been elected to chair of the Legislative Committee of the National Association of Independent Review Organizations, or NIRO. NIRO is an industry trade association dedicated to maintaining integrity of medical peer review and utilization review processes. In this role, Santiago will attend monthly meetings to provide NIRO members with updates on trends, pending legislation, and more. She will also be attending an annual symposium to discuss the latest developments and ideas with industry partners. We'll be right back.
What does better healthcare realized mean? Well, for military veterans and others, it means knowing that their healthcare meets the highest standards of quality. iPro is seeking physician reviewers to join our case review panel for state and federal contracts. We're looking for board-certified physicians with at least 5 years of active clinical experience who currently work at least 20 hours per month on direct patient care. In return, you can work as little or as much as you'd like reviewing cases for medical necessity, appropriateness, utilization, and other measures. You'll be compensated by case and also rewarded by the knowledge that you've helped ensure that the highest quality of care is provided to our nation's veterans and other vulnerable patients. That's what Better Healthcare Realized is all about. Learn more by visiting ipro.org/clinical-reviewers or calling 888-404-6285. That's 888-404-6285.
The American Hospital Association's annual survey of over 6,200 U.S. hospitals includes insightful questions about the role of a PFAC, or Patient Family Advisory Council, within the hospital. The most recent survey data, released in December 2022, indicated that the number of hospitals with PFACs is 51.36%, down from the peak in 2019 at 55.1%. PFACs can play an essential role across the healthcare system by helping providers deliver safe, culturally responsive, and equitable healthcare. More recently, a new term has emerged: Patient, Family, and Care Partner Advisors, or PFCAs, which are individuals who provide insights based on their lived experiences to help healthcare organizations improve the quality of care they deliver. My colleague, Teresa Jacobellis, recently sat down with two individuals who have been deeply engaged with this work. Teresa spoke with Laura Avellino, who is a Senior Quality Improvement Specialist at iPro, and Rosie Bartel, who has been a patient advocate since her daughter was born 2 months premature back in 1978. Here is their conversation.
Well, I want to welcome both of you to Quality Watch.
Thank you so much for having me.
Thank you so much for having me today.
Laura, let's start with you. Can you give us an overview of the role that the patient, family, and care partner advisors can play within a healthcare organization?
Patient, family, and care partner advisors play a vital role in infusing lived experiences into the decision-making process of a healthcare organization by offering valuable insight that might otherwise be missed by clinicians and administrators. They significantly enrich policies and procedures. PFAC engage actively in advisory boards, contribute to quality improvement initiatives, and collaborate in co-designing innovative programs that truly elevate patient-centered care. Their involvement not only enhances the healthcare experience, but also ensures that the voices of those they represent are heard and valued.
Thanks, Laura. Rosie, I'm going to throw it over to you now. We alluded in the introduction to the fact that you first became an advocate when your daughter was born prematurely, but more recently you've had extensive experience with the healthcare system for yourself. So can you briefly tell us about your medical journey and the perspective that gives you, that you bring to your role as an advisor?
Yes, I can share my story. In 2009, I had a knee replacement. This was my 5th joint replacement, so I thought it was going to be very easy. I knew everything about joint replacements. But about 10 days after I had my joint replacement, I started having some problems with drainage from the wound. And then when I had the staples removed, the doctor thought that it was just the staples. But very quickly, in the next couple of days, the drainage became extremely bad, where I was even wrapping my leg in breech towels because that was the only way I could deal with the drainage. And so it was over a weekend. On Monday morning, I called the doctor and I said, I can't even go to work because of the drainage. And, he said, well, come in and this afternoon and I'll check it out. And when I got there, he said, I think I need to change out the hardware. We have a little window of doing that and everything will be okay. And so the next morning at 5 o'clock in the morning, I went to the hospital. 7 o'clock, I had surgery to change out the hardware. And I don't remember anything of that day. So Tuesday was a complete blank to me. On Wednesday morning, I have a new doctor standing at my bedside. And he said, lady, and he probably said a lot of things, but all I remember is, lady, you're very ill. You have a MRSA staph infection. And you have about a 30% chance of surviving this. And that was like, I kept thinking, you don't know me. You don't even know who I am. And now you're telling me I'm going to die. And I've survived cancer 3 times in my life. I had a premature baby because of the cancer. I had all those things. And yet, now you're saying I'm going to die from an infection. And, I ended up having 58 surgeries, over 200 hospitalizations. I survived septic shock 15 times. I've been ambulance flighted any way you can go to a healthcare facility. And I had 3 major amputations and then a tissue removal. So I'm amputated bone and tissue all the way to my waist, other than a little bit of pelvic bone. And, so I always kind of sit sideways because I don't have a butt cheek or a belly button anymore. They took both. They evened me out. But, it's kind of one of those things that, it's funny and we laugh about it because I don't have a butt cheek. But, in the end, I still have a wound that opens up once in a while because once you have MRSA, you always have MRSA. So my goal was to create a world without MRSA. And very soon I realized that, I didn't know how I got this infection. And there were so many ways that I could have gotten it. And, that infectious disease doctor invited me to the table to look at why they had so many infections. And it was overwhelming to me. So I started doing a lot of work with that hospital, but then with Institute for Healthcare Improvement, who heard my story. They came and interviewed me at my home after my first amputation, and then, created a video called One is Too Many. And that video went viral across the world. And so I've learned that telling the story is what is important. I call it storytelling with a purpose. I work with maintenance. I work with environmental services. I work with IT. It's not just doctors and nurses. My infection may never have been involved. The doctor might not have been involved with it, or a nurse or the surgical team may never have been involved with it. It could have came from the air exchange. It could have came from construction that was happening in that hospital at that point. It could have come from a lot of things. I now present to healthcare engineers, construction companies that work in healthcare, because they want their employees to understand the story behind, if they don't do their jobs correctly, then this or that. People can get infections and people can die from what happens to them.
That's an amazing and harrowing tale that you have. And it sounds as if you spent probably as much or more time in the healthcare setting as many professionals. And I wonder, it just occurs to me as I was listening to your story, what role do you think patient education also plays in having people become advocates for their own care? And is that an important role that an advocate such as yourself can play?
Well, I think that many times healthcare providers don't reach out to patients who have a good experience or a bad experience. They just don't talk to them. But yet, on the other side of it is that when you go through something like I did, you have to be ready to tell that story. With iPro, we created the toolkit that talks about the coaching and how to coach a patient. And then I worked on another storytelling guide with the Barrel Institute that we created. I chaired that committee, and there also put in lots of ways of coaching and helping people know when they're ready to tell their story and not ready to tell their story. And it's a fine line, and sometimes you leave parts of your story out because you're not ready to tell it, but yet you can still share other parts of it. And it helping a patient understand that is so critical to everybody in the room, because it's so very important that patients are honored, and when they're wanting to tell their story, that you help them tell their story.
I just want to ask Laura. So I think what happened to Rosie, and it's remarkable, I think, that the facility brought you in at that point and really listened. So Laura, what advice would you give to providers who have not worked with patients in this way before, maybe haven't worked with a PFAC or a formalized or even informal way with patients? Where do they start? How do they get started with this?
For providers who are not yet familiar with working with a PFAC, the first step is to create an environment of openness and collaboration. They can begin by identifying and reaching out to those patients and families who are interested in improving care, actively listening to and incorporating patient perspectives into decision making, establishing an advisory group or participating in an existing one, providing orientation and training for both staff and advisors to set clear expectations. And this is where iPro can help.
How can iPro help with this process? Give us a little more information on that.
Well, we already have an established PFAC, and the materials that we have created, we can share with them, especially our toolkit, our Patient, Family, and Care Partner Advisory Living Toolkit.
So, Laura, I'm going to ask you first, and then I'll go to Rosie with the same question. Can you give us any examples of positive changes or impacts that you've seen as a direct result of healthcare providers really listening to the voice of the patient?
One significant change driven by Patient, Family, and Care Partner is the enhancement of our patient resources. Our PFAC has played a valuable role in crafting, upgrading our patient education. Not only is it clearer, but also more accessible. This significant improvement is directly elevating the patient experience, right, by breaking down informational barriers in healthcare, ensuring that everyone navigates this journey with confidence and understanding.
That's an excellent example. I know it's so important to have material that's accessible and understandable and really impactful for patients to use. Rosie, what about you? Have you seen some really positive changes as a result of your work?
Yes, I've definitely. I work with a healthcare system in the state of Wisconsin pretty much all the time. I mean, I'm there almost weekly, and I've worked with their constructions. I've helped them build an ambulatory surgery center from designing it all the way through to opening it and making sure that all of the things that I believe in were included, like making sure that healthcare is a safe environment and that the experience for the patient is positive from front door to back door. I have a couple of things that I've really been proud of that has happened in this healthcare system. One of them is that I have presented to almost every employee in that healthcare system at some point. And one of the groups that I met with was the maintenance crew. And it was 7:00 in the morning. I looked up and there were, a room full of 200 men who are now looking at this woman who's going to talk to them. And I'm like, oh my God, this is not the experience I thought I was going to have this morning. But yet I shared my story. I shared, what they do could have affected my outcome. And then I always leave groups with, first of all, you're empowered as a professional. Your job is just as important as every doctor and nurse in this facility, because if you're not doing your job well, someone can develop an infection or develop, some kind of a respiratory situation, whatever. But so I always leave them with that. And then I always say, think about the person you love the best and the most in your life. And then would you want them to be a patient in this facility tonight? So I provided this for this maintenance group. And a couple weeks later, the head of facility called me and pulled me aside and said, Rosie, you have made a difference. He said, now they understand why they do the work. It's not just a rule or a reason, but they really understand why they do the work. And I said, what do you mean? And he said, well, we had a problem in a surgical suite where the doctors and the nurses were putting a table in front of the air exchange. And every time the maintenance crew would move it aside, they would put it in front of the air exchange again. And so they had discussions with the nurses and they said, well, this particular doctor wants that table right there. And so we have to put it right there. And so one of the maintenance guys said, well, I guess we're going to just have to leave it. And then there was a man in the room who said less than 10 words a day. He was not a big talker. And yet he said, and what would Rosie say about this? And immediately the gentleman who said, let's leave it, he said, Rosie would say, take it higher and find out, if you don't get action with the people you're working with, go to your boss and your boss can then work it out. So they went to their boss, which was the director, head of facilities, the director of facilities. And he, definitely went to the head, higher up yet. And that table got moved. And so that's one of my stories. The other story is we were working on readmissions. And one of the things that happens with readmissions, and especially I made a lot of calls to patients who had been readmitted over the last few years. We were all making calls. But one of the things I heard over and over was, I didn't get my medication because it cost too much, or, I wasn't able to get to it, or it didn't, I didn't feel right when I took it, or, there were multiple excuses why they didn't take their medication. And so I convinced that readmission group that was looking at readmissions to hire a pharmacist just to work with discharged patients. So when you're discharged, in like the day before or a couple of days. So she goes on rounds, like at least a day or two before they're being discharged. And then she meets with them on the day that they're discharged. And then we also instituted meds to go. And they're 24 hours a day. There are meds to go at that hospital. And so, basically they have the meds before they leave that hospital. So they're not going and all of a sudden being shocked or not able to pick them up because they don't have transportation or they can't afford the copay. And we also talked to a lot of the primary care doctors about, let's not be using those drugs that have these high copays with people that are from, you already know that they have social determinants of health, but yet you give them a prescription that they absolutely can't afford because it will be so high.
first of all, to hear someone call you and say, Rosie, you've made a difference must have just made your day. I mean, that's why you're doing this. And then to know that you're helping people access their medication who might not have access to that medication is an incredible accomplishment. So that's just two great examples right there. So I want to think about what types of organizations do you think are best suited for PFACs or PFCAs? So Laura, what have you seen? Is this a model that works in, across the healthcare continuum? Are there specific types of providers that are more well suited to this?
PFACs can be valuable in hospitals, outpatient clinics, long-term care facilities, mental health facilities. I would say even insurance companies, wherever we have patients. The model is gaining momentum as healthcare shifts towards patient-centered care. And with the growing recognition of its benefits, it is likely that it can be used in all healthcare settings.
And it sounds as if you do see this growing and spreading, both of you. I'll throw that out to both of you. It seems like it's something that you anticipate seeing further growth.
Hospitals now have to have a PFAC that is connected to the patient quality and patient safety. And, it's part of the patient safety structural measures. Now, there's a whole section in there. It talks about you have to have a patient advisory council, it's patient engagement. You have to have a way that patients can interact with their, and the transparency and their patient portals. You need to have patient portals and interactive patient portals so that patients can interact with their clinicians on a regular basis. So there's, the patient engagement piece is very strong in the structural measures and also in the IHI self-assessment piece.
Well, it sounds as if we're fortunate that you've given us this time today because you are a very busy person. You're involved in a lot of different areas with a lot of different organizations, which is amazing. Laura, I want to ask you, do you have any final thoughts before we wrap up the conversation?
Just thank you for the opportunity, and also with the growing evidence that involving patients and their families in the decision-making process is not only for improved health outcomes, but also patient satisfaction and overall just better coordination of care when patients feel more involved.
Absolutely. Rosie, what about you? Final thoughts for us?
Let's make sure that we share the stories so that patients can have better outcomes. Storytelling with a purpose is so important to me, that we share stories and find ways to share stories across all parts of healthcare, not just hospitals, but every area of healthcare.
Well, thank you both so much for joining us. This has been a very insightful conversation. We will provide links to resources where you can learn more about PFACs and the whole concept on our Quality Watch page or on our website at ipro.org. That's IPRO.org.
Thank you for the opportunity to share today, and I really, really appreciate the work that iPro does. I'm a big supporter of iPro. So,
thank you so much for the opportunity today.
It's time for us to crunch some numbers in our Data Watch portion of the program. Heart disease remains the leading cause of death in the United States, where it claims nearly 700,000 lives each year. From 2019 through 2020, the cost of heart disease to the American healthcare system was over $250 billion, according to the CDC. And recent reports from the CDC show that the U.S. life expectancy increased in 2023. The death rate for the entire U.S. population decreased by 6% from 798.8 deaths per 100,000 in 2022 to 750.5 in 2023. As a result, life expectancy at birth for the U.S. population increased from 77.5 years in 2022 to 78.4 years in 2023. That's it for this episode of Quality Watch. I'm Dr. Edison Machado, and on behalf of iPro, thank you for listening. To learn more, visit our website at ipro.org. That's IPRO.org. And if you enjoyed this podcast, please leave us a comment and subscribe wherever you listen to podcasts. We'll be back next month with more. And until then, we'll be working on better healthcare realized.